Upper GI cancers: oral, esophageal, and gastric. Oral cancer can originate from the lips, mucosa, gums, hard palate, floor of the mouth, salivary glands, and anterior two-thirds of the tongue. Most often it is squamous cell carcinoma. The clinical symptoms would be mucosal erythroplasia, which is a red inflammatory mucosal changes. It appears smooth, granular, and minimally elevated and could contain leukoplakia, which is the white component. Cancer of the lip is a lesion that does not heal. Cancer of the tongue is swelling with red velvety patches on the mucosa and is suggestive of erythroplasia, which is a precursor to squamous cell carcinoma. The floor of the mouth cancer has elevated mucosal lesions, leukoplakia, ulcerations, and wart-like growth. Cancer of the tonsils is swelling in the neck base, odynophagia, which is painful swallowing. Symptoms of oral cancer could include, besides the white or red patches, bleeding in the mouth, loose teeth, problems or pain with swallowing, a lump in the neck, or an earache. Diagnostic evaluation would be careful inspection of the oral cavity. They may do a flexible or rigid nasopharyngoscopy, which is to visualize the nasopharynx and pharynx. Staining of the oral lesions with the toluidine blue, which darkens the lesions after rinsing with acetic acid. Normal tissue does not absorb the stain. They also could do an incisional biopsy, radiological tests like chest x-ray, CT, MRI, and a PET scan to determine invasiveness and metastases. Surgery is a common treatment for all stages of lip and oral cavity. Early stages can be removed by incision and treated with radiation and chemotherapy. Large lesions can be treated with radical neck dissection followed by radiation and chemo. Surgery may include a wide local incision which removes the cancer and some healthy tissue around it. If cancer has spread into the bone, it may need removal of the involved bone tissue. The neck dissection is removal of the lymph nodes and other tissues in the neck, and this is done when cancer may have spread from the lip and oral cavity. There are two types of radiation therapy. External radiation uses the machine outside the body to send radiation toward the cancer, and an internal radiation therapy uses radioactive substances sealed in needles, seeds, wires, or catheters that are placed directly into or near the cancer. The way the radiation therapy is given depends on the type and stage of the cancer being treated. For patients who smoke, radiation therapy works best when smoking is stopped before beginning treatment. It's also important for the patients to have a dental exam before radiation therapy begins so that existing problems can be treated. Chemotherapy. Cancer treatment that uses drugs to stop the growth of cancer cells and is done by either killing the cells or stopping the cells from dividing. The side effects depend on the drugs they receive, but the most common side effects are nausea, vomiting, and hair loss. Targeted drug therapy for people who take part in clinical trials can also improve the way cancer is treated in the future. One targeted therapy approved for treating head and neck cancers is cetuximab, and it stops the action of the protein that's found in many types of healthy cells but is more prevalent in certain types of cancer cells. Nursing management. Ask the patient regarding any changes in swallowing, smell or taste, salivation, or discomfort when eating. In addition, ask about a sore throat, foul breath odor, weight loss, epistaxis, changes in vision. If the patient is unable to brush teeth, then gently lavage the oral catheter with warm water, salt water, or sodium bicarbonate solution rinses. Insert a gauze to wick in the corner of the mouth to catch drooling. Carefully suction secretion. If a patient has decreased salivation, then encourage intake of fluids. Patients should avoid dry, bulky, and irritating foods, and chewing gum can stimulate salivation. Encourage the use of humidifiers, and suggest foods with sauces and gravies to make them moist and easier to swallow. Encourage possibly a follow-up with the speech-language pathologist if they need it. And patient teaching would include decrease or stop smoking, alcohol, smokeless tobacco, and pipe smoking. Now I put in here stomatitis just because it is similar. And it's an infection that causes painful mouth sores and ulcers, and it's caused by a virus, so antibiotics will not help with the treatment. These mouth sores and ulcers may be found on the gums, lips, and back of the throat. There may also be a rash on the hands, feet, or buttocks that is often called hand, foot, and mouth disease. The rash may last from 4 to 7 days, but may last up to 2 weeks. Stomatitis is contagious, and it's contagious until all the sores and ulcers heal and the fever is gone. A small number of people who have stomatitis can get it again. So basically we're looking at stomatitis that treated for 2 weeks, and if it's still there, then they would need to biopsy it for oral cancer. Esophageal cancer is a malignant lesion of the esophagus in the distal and middle third of the esophagus and is most common in males. It is associated with Barrett's esophagus, chronic use of alcohol, tobacco, ingestion of caustic substances, diets low in fruits and vegetables, exposures to lye, asbestos, and metal, and a history of achalasia, which is a rare disease of the muscle of the esophagus. The term achalasia means failure to relax and refers to the inability of the lower esophageal sphincter to open and let food pass into the stomach. As a result, patients with achalasia have difficulty in swallowing food, and treatment for this is usually an endoscopic and laparoscopic procedure. The early clinical symptoms would be difficulty swallowing, losing weight without trying, chest pain, fatigue, chronic cough. Later signs would be progressive dysphagia, pain develops late, and hemorrhage if it erodes into the aorta. Also later symptoms would be hiccups, respiratory difficulty, foul breath, regurgitation of food and saliva. Symptoms of gastrointestinal bleeding would be black stools, vomiting blood, or material that looks like coffee grounds, and that could be from an esophageal perforation with a fistula formation or an esophageal obstruction. Metastases to the liver and lung are common, and if the tumor is in the upper third of the esophagus, then a patient could experience sore throat, choking, and hoarseness. When the esophageal cancer has spread to organs beyond the esophagus, long-term survival is not common. The chances of recovery improve when it's detected at an early stage, but in most cases, the long-term survival remains below 30%. The diagnostics. An endoscopy is done to examine the esophagus, looking for cancer or areas of irritation. A patient should not eat prior to the ultrasound because food intake can cause the gallbladder to contract and alter the study. The patient should be NPO for 8 to 12 hours before the test. An endoscopy of a Barrett's esophagus is beneficial to show early detection of malignant changes. Keep in mind that if a patient has an elevated temperature after an upper endoscopy, it may indicate that a perforation has occurred. It's normal for a patient to have a sore throat after an endoscopy, and no food or fluid should be given until return of their gag reflex. A barium swallow coats the lining of the esophagus so that the lining clearly shows up on the x-rays. This may show lesions that may require biopsy. A CT may show extent of tumor and presence of tissue metastases, and chest x-ray could show metastases or tracheoesophageal fistula. If they do an endoscopy or bronchoscopy, it's done to collect tissue samples too for biopsy. Surgery would be very early stage cancers and can be done using an endoscope to assess the cancer. Surgery may be done to remove portion of the esophagus, which is esophagectomy. And during an esophagectomy, portion of the esophagus that contains the tumor along with nearby lymph nodes would be removed. The remaining esophagus would be subject to radiation therapy. External radiation sends radiation toward the cancer, and internal radiation uses substance sealed in needles, seeds, wire, or catheter placed near the cancer. Chemotherapy could be a combination with radiation therapy, and in advanced cancer that has spread beyond the esophagus, chemo may be used alone to help relieve signs and symptoms caused by the cancer. Laser therapy uses a beam, it's a narrow beam of an intense light, to kill the cancer cells. Electrocoagulation is use of an electrical current to kill the cancer cells. Nursing management. These patients usually have a poor prognosis, as the cancer is usually not diagnosed until advanced. So management would be curative or palliation, and that's where the radiation and chemo comes in. With the esophagectomy, a Dacron graft is used to replace the removed section. After a laparoscopic esophagectomy, the patient should elevate the head of the bed to decrease the risk of reflux and aspiration of gastric secretions. Complications would be pre-op issues like malnutrition, aspiration pneumonia, hemorrhage, sepsis, tracheoesophageal fistula. Post-op problems are pneumonia, dumping syndrome, nutritional deficiency, reflex esophagitis, and anastomosis leakage. So monitoring the blood pressure, pulse, respirations, and temperature for early detection of hemorrhage, infection, dysrhythmias, aspiration, or an anastomotic leak. Check blood gas levels, manage pain, observe incisional drainage, or if the chest tube is placed, to check for bleeding or purulence. The nursing assessment, the health history, asking about dysphagia, pain, cough, or hoarseness. Evaluate for weight loss and dietary changes. High protein, high calorie diet, and TPN may be ordered. Checking their post-op IV fluids for their eyes and nose. Assess their bowel sounds. The patient may end up needing an NG tube. Advance the diet from liquid to soft foods when they are able. The patient should remain upright position for 2 hours after eating to avoid reflux, and pain management for mouth care, for comfort, and for hygiene. Patient teaching is to avoid overeating, take small bites, and chew their food well. No chunks of meat or stringy raw vegetables or fruit. Gastric cancer is a malignant tumor of the stomach. It's important to have an understanding of the cells within the stomach. The parietal cells secrete hydrochloric acid and intrinsic factor. Intrinsic factor is necessary for the absorption of vitamin B12 in the small intestine. The mucus cells produce mucus which clings to the lining of the stomach, providing protection from gastric juices. Zymogenic cells produce pepsinogen. This is good because it degrades food proteins into peptides. Enteroendocrine cells produce hormone-like substances which diffuse into the blood. The early signs for patients would be loss of appetite, early satiety, which is gastric fullness, dyspepsia lasting longer than 4 weeks, blood in the stool, and vomiting may indicate a pyloric obstruction, or vomit that appears coffee ground could be a slow leak from ulceration of the cancer. Coffee ground emesis will most likely need an endoscopy for visualization and diagnosis of upper GI bleeding. So questions for the nurse to ask would be about loss of weight and how much and over what period of time. Does the patient feel full after eating small amounts? Is there pain? Do foods, antacids, or medications relieve the pain? And then the nurse should perform the physical exam to assess the abdomen for tenderness, masses, and palpate the abdomen to detect any ascites. Later signs of gastric cancer are pain with eating which is relieved by vomiting, loss of strength, anemia, metastases to the liver, hemorrhage, or obstruction. Ascites is a poor prognosis. You may be able to palpate an abdominal or epigastric mass. So if the patient was having nausea and vomiting, they would need to start with clear liquids and proceed as tolerated. Avoid acidic drinks like orange juice or hot foods. Watch for dehydration and hypotension. It's probably best to infuse normal saline to prevent them from getting dehydrated. The physical examination may not be helpful in detecting the cancer because most early gastric tumors are not palpable. In advanced cases, the gastric mass would be palpable. An ascites and hepatomegaly may be apparent if a metastasis has occurred. Esophagogastroduodenoscopy is done for biopsy, and cytologic washings is a diagnostic study of choice. The CT completes a diagnostic study to assess for surgical resectability of the tumor before surgery is scheduled. CT of the chest, abdomen, and pelvis is important in staging of gastric cancer. Part of the diagnostic evaluation is to ask about a history of weight loss or fatigue over several months. This could indicate gastric cancer. Beside the endoscopic ultrasound, complete blood count, urinalysis, stool exam, liver enzymes, and serum amylase would be done. The upper GI X-ray and endoscopy would obtain samples for histologic and cytologic review. A bone or liver scan may determine the extent of the disease. There are tumor markers that would be checked: the CEA, the CA19, the CA125, and the VA72-4. Management would be surgical removal of all or part of the stomach. If the tumor has metastasized, then palliative surgery may be done. The surgery may be a total gastrectomy combined with chemotherapy. Successful treatment of gastric cancer is through tumor removal. A cure could be achieved if the tumor had been removed while it was still localized in the stomach. Otherwise, a cure is less likely. Unresectable tumors in a patient with advanced disease, chemotherapy uses a single-agent chemotherapeutic medication including bifluorouracil, cisplatin, doxorubicin, and mitomycin. It's now more common to administer combination therapy, primarily the 5-fluorouracil-based therapy with other agents. Once a patient has had a total gastrectomy to resect the cancer, the entire stomach, duodenum, and lower portion of the esophagus and the supporting mesentery and lymph nodes could be removed. An esophageal is performed to reconstruct the GI tract. Complications would be a risk of hemorrhage or infection, and dumping syndrome following a gastrectomy, and ultimately metastases and death. Nursing assessment is to prevent shock and hemorrhage by checking blood pressure, pulse, and respirations. Look for mental status changes, pallor, clammy skin, or dizziness. They'll need IV infusion and possibly blood replacement. Continue a respiratory assessment and encourage cough and deep breathing and promote ambulation. Thrombosis and embolism prevention would be by use of a TED hose or sequential devices. Check for dumping syndrome. The patient would need to eat 6 small frequent meals, a diet high in protein, high in fat, and low in carbohydrates. Avoid sugars, milk, chocolate, and salt. They should not drink fluids with meals, but drink between meals. And resting after meals, and possibly take an anticholinergic medication before meals to lessen the GI activity. Other nursing interventions would be relieving pain, administering analgesics as prescribed after assessing the level of pain, encourage non-pharmacological methods for pain relief, and providing psychosocial support. Help the patient express fear, concern, and grief about the diagnosis. Answer their questions honestly and encourage them to participate in the treatment decisions. Offer emotional support, and involve their significant others. The expected outcomes would be report less anxiety, attains optimal nutrition, has less pain, performs self-care activities and adjusts to lifestyle changes, and if the cancer has metastases, then possible referral for hospice, palliative care to prepare for the dying process. Patient teaching once they go home is to avoid high carbohydrate foods like milk, which could trigger the dumping syndrome. Patients should have a diet high in protein and calories to promote wound healing, and B12 supplements after a gastrectomy to prevent surgically induced pernicious anemia.